All right. And we should be live. Hi, everyone. Apologies for the delay. We had a few technical difficulties, but welcome back to another session with Dental Shadowers. We are very excited to welcome our guests, Dr. Otto and Dr. Fraundorf, both of whom are orthodontic providers practicing in St. Louis. Doctors, thank you so much for taking the time out of your busy schedules to join us today.
Yeah, thank you.
Please feel free to take it away whenever you're ready.
All right, cool deal. Well, thank you so much for having us. We are so excited to be here. This is such a cool avenue to be able to share things with colleagues and future colleagues and things like that. So we love that you guys put this together. So bear with us. We are gonna kind of talk a lot during this. I know afterwards we're gonna have some questions and things like that. I did a little pop-up box on my Instagram. So we have a bunch of questions from Instagram at the end as well. So we'll do a lot of Q&A at the end. All right.
Love it.
Oh, there we go. Okay, so our practice, as he just mentioned, is in St. Louis, Missouri. So we have 3 locations right now. And this is our De Pere office. So do you want to explain a little bit about that office?
Yeah, so we'll kind of get into this later, but this is the startup that was done in 2018. So this was built from scratch. So it's nice and modern and brand new. Has 5 chairs you can kind of see in the clinic there. This is the waiting room. And then we have a couple other offices that were purchased that were already existing. So did some rehabs, and so everything's kind of nice and modern and clean. That's kind of what we try to
emulate.
Yes, exactly. Yeah.
So in the top right corner, you guys can see our braces off bar. That is probably our patient's favorite thing. It is a highlight, and it is for us a big temptation to not eat candy all day long. But that braces off bar we have in every office now, and to me, it's kind of a fun thing that you can do in private practice.
So it's for the kids when they get their braces off, they get to fill up a big cup of candy, and it's the candy that they haven't been able to eat this entire time.
The liberating moment.
Yeah.
Yes. So this is just a little view of Dr. Otto and I went to dinner after the 3rd office was purchased officially in September. So we like to work really hard, but we also like to have fun, and we are really good friends, which helps everything so much.
So this is just a little bit about me. I was born and raised in St. Louis. I went to the University of Missouri in Columbia, which is just like about an hour and a half away from where I grew up. Have a major in biology, minor in chemistry. So the pretty typical pre-med, pre-dental route. I didn't really know I wanted to do dental right away. So I was kind of on that pre-med route. But surprisingly, my roommate in undergrad at Mizzou, at the University of Missouri, she was actually pre-dental from day one. Her sister was in a dental program. And so had I not had her as my roommate, I'm not sure if I even would have gone down that path. So I went to the University of Southern California for dentistry. And then I immediately went into St. Louis University for my orthodontic residency. And so I graduated in 2010, a long time ago, from SLU, and basically went into being an associate. And I think we're gonna get into that a little later. But I went into dentistry, really not knowing for sure I wanted to be an orthodontist. And I learned a lot about orthodontics while I was there, and it really fit my personality. But I did have braces and an expander and headgear and positioner, and I really enjoyed my orthodontic experience. So I think that really helped why I was interested in that when I went into dentistry. But yeah, it's a very cool, big picture, almost artistry that really suits me.
Right.
And so that's kind of why I went into it. But so right when I got out of residency, I went and I was an associate at St. Louis Orthodontic Group, and I associated there. I basically was really thrown into it. I mean, it was hard. I mean, I went from seeing about 5-7 patients a day to about 75. It was a pretty fast-paced practice. And so, I mean, that teaches you a lot though. So I went in, there was actually 4 other associates, but we never worked together. We always were at different offices. So I could kind of talk to them about treatment plans, but I was seeing everyone on my own. So after about 5 years, I purchased one of the offices of St. Louis Orthodontic Group. So there was 4 or 5 practices. So I purchased an office in Wentzville in 2015. And that was a 1-day-a-week practice, and it's now grown. We've pretty much, I don't even know. I mean, it's like 10 times the size that it was back in 2015. Then in 18, I did the startup in De Pere, and then purchased another one of the St. Louis Orthodontic Groups in another location in Fenton, and that was just done in September. So now 3 practices.
How was that transition from, I guess, from dental school to essentially the workforce?
You know, it was, like I said, it was hard because of the quantity of patients I was seeing.
Right.
And in our residency, my biggest complaint, I would say, and I don't know if this was just with SLU, was I didn't feel like they really got us ready for real world, like how we really see patients. They teach us so much. They teach you so many techniques. So you're able to go into any practice and know the technique that that person might be practicing, but is that the way you want to practice? You know, they may have been practicing that for 20 years and there's a better way to practice. And it could have been different now. I mean, that was, 10 plus years ago when I got out, but I felt like I didn't know the real world. Like, how do I really treat patients efficiently? So,
Right.
So that was the hard part. And then just seeing so many people a day and really having to get your speed up. I mean, just like you would have to do in dentistry when you get out of school.
Yeah.
But I really focused on the orthodontics and learning that. And then slowly that was just on autopilot. And then the business side of it is what I've been really trying to perfect the last couple of years.
Interesting.
Okay, so I am ERIN. I am from Milwaukee, Wisconsin, suburb outside of Milwaukee, but nobody knows where Menominee Falls is.
How do you even say that?
Yeah. So I went to school in Wisconsin at Wisconsin La Crosse, got my bachelor's degree in 2012. I majored in biology with a biomed concentration, biochemistry. So again, standard pre-dental kind of subject matter. I also majored in Spanish because I wanted to. And then I minored in art. No, I wish I were. It's been, I mean, in Missouri, you don't really have too many Spanish speaking patients. So don't really use it anymore. And, you don't use it, you kind of get rusty. So then I went directly from there to Louisville and went and got my dental degree from University of Louisville School of Dentistry, graduated in 2016. And then immediately from there, I went to SLU also. So we both went to the same residency at different times. But it's kind of funny, and what kind of eventually got our paths crossing, I had a few professors that said, "Oh, you remind me so much of this resident that went here a few years ago, blah, blah, blah." And I was like, okay, cool, whatever. And then a few years later, we end up kind of matching up, and the rest is history. So why dentistry and orthodontics? So I had a root canal from trauma on one of my central incisors when I was 11. And just after that, I was like, totally want to do dentistry. I didn't go into dental school thinking I wanted to do orthodontics. I did not have the best orthodontic experience as a child. He just wasn't the nicest orthodontist. So I went into school thinking I wanted to do oral surgery or endodontics. Kind of explored it a little bit and soon realized that orthodontics just so much better meshed with the lifestyle I wanted, the type of personality I have. I like to enjoy my patients and I want them to enjoy me. And I don't want people coming to me like in excruciating pain and being terrified and all that other stuff. So I like that people choose to come see us for the most part, or their parents choose to bring them to see us. And we get to develop a relationship with them over time. I love that orthodontics is that kind of artsy field, and it kind of lets us use our hands a little bit more as far as, making a puzzle and stuff like that. So that's why I went into that. My practice history is a little bit less extensive. So upon graduating, I immediately started with a corporate group. So there are a few different corporate orthodontic practices throughout the country, depending on the area you're in. Pacific Dental Services is one of the bigger ones. And I worked with them for about a year and a half. And then in that time, I also started working with Dr. Otto. So we started 1 day a week. I was an associate orthodontist at her office in Wentzville. We were just trying it out. As you can probably imagine, practicing, with somebody close knit, you have to get along really well. You have to have your personalities mesh. You have to have your families mesh. You have to have your, practice ideals, mentalities, your culture,
Right.
as far as clinical things, all of that has to kind of match up. So it was kind of like we dated for a while. We did a little trial of 1 day a week, and then eventually it just worked out really well. And so now I'm with Dr. Otto full time. I go between our Wentzville and Fenton locations. So talked a little bit about multiple doctor offices. Obviously, you can be in a solo private practice. You can be like I was with a corporate group and being a solo practitioner. You can be like Dr. Otto was before in a big group with lots of doctors. So I'll talk about my experience as far as being a corporate doc, and then if you want to touch on
that's
your
totally
stuff.
different than what I did.
So corporate, I liked, starting that route. It was a little bit scary that I started the practices or not the practices, but the ortho side of things from scratch. And, you have to build a patient population on your own. It's kind of crazy going from a residency where you have 13 co-residents, where you're constantly talking about cases and you're working together and you're like with colleagues constantly. And then you're thrown in, okay, but you're by yourself, figure it out and, do what's best. So, obviously in the world of technology, it's nice you can still communicate with each other. And with orthodontics, it's such a brain powered specialty that you can really still have that collegial atmosphere, even when you're not directly working with somebody. But that was different for me. I was very fortunate. I had an assistant that had extremely great experience, and she was amazing. She had worked for, I think, like 15 years as an assistant. And so when I got her, I learned as much from her as she did from me, and we worked together so well. So it was definitely a great experience. I would say the downsides for me for corporate was I like to kind of integrate the fun side of orthodontics and the patient experience and the kind of like that clinical culture I was talking about, and just having a really good kind of family atmosphere that's centered around orthodontics and that whole patient experience. And I felt like that's something that's challenging with corporate, just because the offices that I was in weren't solely orthodontics, and I just didn't have as much control over that atmosphere. So do you want to talk about your the multiple group?
So when I came out and joined, it was 4 doctors, but there was 4 offices. So we would travel to different offices, and I would go to, maybe 3 or 4 offices a week, which was fine. I didn't love that because I kind of wanted to see the same patients and a little easier to remember them and, have good camaraderie. And then you kind of kept your treatment plans the same. So we ended up changing that up fairly soon after I started. So I was just at 2 offices, which was really nice. So even though there was 4 doctors, I kind of was out of school. It was nice because I did learn from what they had done previously. My mindset when I was trying to find a practice was, I've been in school for so long. Do I really want to work side by side with, a 55, 60-year-old man or woman and kind of still have that learning atmosphere? When I look back, I think if you found a great clinician, that would be phenomenal, because there's so much you don't know. And to have just someone teach you one-on-one for a year or 2, you'd be set. And I think I am a good clinician now, but it took me a little bit longer maybe to get there out in private practice, because I had to figure it out on my own for the most part. Because in residency, you don't get to try all of your appliances. You don't get to see those cases all the way through. So I now use appliances that I never got to use in school. So I had to figure it out on my own. But there's a lot of docs out there that have already figured it all out and could have just given it all to you on a platter. So
Right.
there's kind of some give and take there where I was on my own, I was independent, I got to do whatever I wanted to, but I feel like it took me longer to get exactly what works well in my hands. It took me longer to get there, which is fine, but probably a little bit more stressful than needed to be had I had one-on-one and had that mentor. But I still had those other doctors that I could shoot them a case. And honestly, no, now in the world of like the Facebook groups, I mean, it's nice because her and I talk so much and it's so easy, but you can easily post a case on Facebook and get, 10 different opinions and kind of solidify, okay, yes, that's what I was thinking. I feel good about this decision. So that's really nice for everybody coming out of school right now. The Facebook groups are phenomenal. They're amazing resources.
Yeah, I always tell people it's literally the only reason I'm on Facebook anymore.
Same.
Is
are my 4 like ortho groups.
Yes.
Very, very dorky.
Yeah. So now that it's the 2 of us, I guess some of my favorite things are the things that we kind of bullet pointed here. So I like that we share patients. I will say it's a totally different experience having your own patients and seeing them every single time. So it was tough for me to come into the office when they're like, oh my gosh, you're not Dr. Otto. And I'm like, I know, I don't blame you. She's amazing. I love her too. But we communicate all the time. And so that was a challenge, but I love it now. I think like Dr. Otto said, it's the case discussion. I mean, we're texting each other probably like 100 times a day, minimal, and FaceTiming and constantly talking about cases and bouncing ideas off of each other, because there's so many different ways to treat cases in orthodontics that it's just interesting to get different perspectives and like, okay, you could treat it this way, you could treat it this way, and what are the pros and cons of each, and kind of, like Dr. Otto said, she has a lot of experience now over the years that she's tried things and what works best in her hands. For instance, there's an appliance, class 2 corrector, the Mara appliance versus the Herbst appliance. They're both functional appliances. I only had experience with one case in residency with a Mara appliance. And so I had never done a Herbst. I had no idea how they worked. I was like, they're huge, they're bulky, I don't want my patient to have them. And then, we talked about it and she showed me cases and she showed me, literature and everything. And I was like, oh my God, I'm sold, let's do it. And it's been phenomenal. So I would have never come across that had we not been together.
And it's interesting because I never had a Herbst case in residency, but my good friend went into practice with her dad. And so she actually taught me their protocol and it works amazing. And that's kind of going back to, you had that mentor that, hey, I know this works. It works great. We have little emergencies and we see good results. And they you had to design it a certain way. And like, I actually had used them a little bit right out of residency and I was like, I don't like these, but we changed the design a little bit and now they work great.
So a few other things,
Amazing.
we get to share responsibilities. So, that's kind of self-explanatory. We balance each other's strengths. So Dr. Otto is obviously phenomenal at the business side of things. She knows how to do all of those things. She knows how to, handle employees. I'm still learning about that stuff and kind of balancing everything. She knows how to run a practice and she has that expertise in the orthodontic realm as well. I feel like I bring a little bit more of like a fresh kind of marketing, social media based perspective, where I'm like, you know what, you are phenomenal. Let's make sure people know about you. So
I'm like, I've never heard a story. How do you do this?
Yeah,
It's a perfect working balance.
Yes. So if you guys follow us on Instagram, the stories that we posted the other night were Dr. Otto takes video, sends it to me on text, and then I post them. So it's a great balance because, what I don't know, she knows. What she doesn't know, I know. And it's awesome.
Yeah.
Right.
Other thing, especially, when you're a female at our age, one thing that you want to think about is, having kids. And I know a lot of, female clinicians are like, oh my God, what am I supposed to do? So having that ability to have that balance, being able to take vacations and not worry about emergency patients because the other doc is in the city and can take them. We haven't been sick, knock on wood. But, if you're sick and you need coverage or, your kids or something's going on. So it's just nice to be able to have 2 people that are sharing patients. And so it's not a big ordeal.
Yeah, especially with COVID. I mean, we were terrified, like from a business standpoint, I'm like, if I have to shut down for 2 weeks plus, I mean, that would be a nightmare. But thankfully, like if that happened, I would have someone to run the offices and we wouldn't have to shut down.
Yeah. And then obviously friendship, which we've talked about. Okay. Okay.
Love you. Call you in 5 minutes.
No, but buddy, don't, you don't have to call me, okay?
Good idea. You call me.
Okay, I'm gonna hang up now.
I painted a picture of a butterfly.
Good. I'm gonna hang up.
I drew the piano.
So that's just to kind of show that's really
love
our
it.
relationship.
Mhm.
But also to kind of show, that's something that is a little bit more fun to do when you have multiple docs, is you can do silly stuff like that and like be like, okay, well, we look stupid together, it's fine. Whereas like if, I would never do that by myself. So that's one thing.
I didn't even know what TikTok was.
All right, so advice for pre-dental students. You want to take it away on this?
Yeah, so I mean the obvious. I mean, you have to get good grades. You have to get a good DAT score. This was so long ago when I went into it. I mean, for me, it was being a leader. Showing that you're well-rounded, doing tutoring, doing anything you can to just display that you're different from just everybody else. Because I mean, at this point, every single person has above a 4.0 and has a good DAT score. So it's showing that you stand out from others. I think what I just learned recently, and this pertains a little bit more to getting to ortho school, but same for dental school. I'm helping actually one of our assistants right now wants to applying to dental school, and it's crazy. I guess a lot of it's pass fail, and I'm so curious as to how these applicants are supposed to stand out. I mean, when I was there, it was grades and board scores, and a lot of these things are going pass fail. So we met with her and I met with another doctor, and that actually knows a lot about the school and was just kind of trying to get some insight. And he was telling us so many interesting things about the school. And he's like, it's so important that you know a lot of information about the program you're applying to. He's like, you should know everything. And not sure I would have done that. I mean, know like all the little things about a school.
Right.
One of the schools she's applying to, is basically see a ton of Medicaid patients, and they have a lot of outreach programs, and that's something I didn't even know about the school, and I should have. But so knowing a lot about the school, and I think she's getting a lot of exposure to orthodontics, which is probably going to set her a little bit apart because she's been with us for about a year.
I would say along with that, one thing that she was talking about is relationships are huge. The fact that that assistant is working with Dr. Otto and she has that connection opens up an entire world of other connections. So that general dentist that they met with, that's a huge connection for her that she wouldn't have had if she didn't make a connection with Dr. Otto. So, and I think now more than ever, relationships are so easy to make, and even more important than ever. So I think that to me nowadays, like you were saying, it's hard because everyone has good grades. Everyone's good at this, and everyone does this and this and this. That's a huge thing that sets people apart. When I was pre-dental and I was in undergrad, I worked at a dental office, a general dental office, and I assisted. I luckily got paid for that, which was amazing, but you could also intern at an office and, get that exposure, get really good letters of rec from them. Additionally, you can see in the picture, so I went to Ecuador a few times. So having experiences like that, that you can, use as an experience that you can share with them, whether it's on your story or in an interview or whatever, and just something interesting about you. I think for dental school, but even more so for ortho, which we'll talk about kind of in a second, but it's so important to be interesting, especially when you're in a really small residency. They don't want to hang out with somebody that's like super book smart, but like
no personality.
Yeah, no personality, like horrible. So that's something to look at as well. So advice for kind of ortho stuff is our little other TikTok.
This was a hard one.
It was.
Nothing can stop me. I'm all the way.
So one thing with this is, obviously you're going to have to give up your life in dental school. I did not go to a pass-fail school, but I know during my time, there were a few pass-fail schools kind of popping up.
Mine was one of them.
Yours was?
USC, we didn't have a rank.
Oh, wow.
Yeah.
So at those times, the only people that I knew of that were pass-fail that got in had connections. So, whether you're the child of this person who knows this person and whatever, or you worked with this person or whatnot. So if you're pass fail, you really need to get to know people. You can shadow. Obviously now it's virtual, but you could, get to know the program director, different course people, whatnot. Like we said, grades are number one. Board scores, GRE scores. I honestly don't even know. What are you guys taking nowadays for ortho? I know it was GRE when I took it. It was
Same.
boards.
Well, no, for you to do GRE too.
You
Boards
didn't-
and
oh,
GRE,
okay.
yeah. And you
I
can
only
get
have to
above
do GRE.
a certain, you didn't do board scores?
Mm-mm.
First, oh my God.
We didn't have scores on boards.
Oh, that's right.
Yeah, it was
Oh.
pass fail.
You
Anyway.
had to get like above a 92
Yeah.
at least to be even considered.
So getting that exposure to the field, making sure you love orthodontics as much as you possibly can in this realm. Again, relationships and extracurriculars. So make sure you're well-rounded and a cool person. All right, so here's some basics of orthodontics.
In our specialty, so what are we talking about here?
Just kind of general information about ortho. We were trying to, do stuff that other, people didn't do, but here's some general stuff. So just prevent, diagnose, and treat dental and facial irregularities. Orthodontics, much more than other specialties, is more so about like the brain work and the puzzles, and
the diagnosis is really the biggest
diagnosis
thing.
is everything. So after, we do the diagnosis and everything like that, you get into your kind of realm and your set protocol, and it becomes a little bit more standardized. So, we have phenomenal assistants. They are so amazing, and they get to know how we like to practice, and they're like mini orthodontists. So we come over to the chair and we're like in the middle of treatment and we have all of our notes, and they're like, okay, we're going to be bumping to a 1622 steel today based on, what we discussed last time and based on what you usually like to do, kind of thing. So it's really that brain work, and a lot of it's up front. So that is one thing I would say. We do a lot of hand work, as far as we bending wires, we do some polishing on enamelplasty, we do some gingivectomies, we do, when we're behind and stuff, we'll put wires and we'll tie in and we'll do different things like that. But a lot of the times the assistants are doing the more like physical part of it, and we're doing the more mental part.
And I think that's the most, I still have fun. It's almost like a little bit of a game, like a puzzle.
Totally.
Like whenever you're diagnosing and you see a hard case come in, you have to, that new patient's in the chair, I get about 10 seconds to look at it, and then I have to know exactly what I'm going to explain to that parent. So at the beginning,
It's like a rush.
yeah, at the beginning, it's really, really nerve wracking because you don't know. You
Put
know,
on the spot.
and you just gotta go. You gotta go with it. You gotta go with your gut. And sometimes you're gonna say, look, I need to look at these records further, and here's here are some options, and we're gonna meet again. And now, we very rarely have to do that. We still have very hard cases that come in, and I just say I can give them a lot of different options on what I'm thinking, but I'm like, I really have to sit down and look at numbers and put this puzzle together. So it really is fun, and that was kind of the interest for me in orthodontics, was that putting that puzzle together.
Yeah. So like you're saying, there's so many different ways to do the same thing. And what's the best way for not only us mechanically, but the patient lifestyle wise to get that end result. So, it's very aesthetically centric. We have a lot of patients that do come in for functional things or teeth that are impacted, and it's more of a, a health related thing, but I feel like there's a big spectrum where it's, the need of orthodontics is, to me, a spectrum of how much can a patient benefit from this. Sometimes it's more just cosmetic, sometimes it's more towards that functional end of the spectrum. So we always, are very transparent with our patients and say, you know what, you have a crossbite, this is what's going to happen if you leave this crossbite untreated. Will you die from it? No, but here's how it's going to affect your life and your dental development and your TMJ and this and that. So that's kind of with orthodontics different than general dentistry. Usually people are choosing to be there. We've got a very large patient load, but we have, like we said, many orthodontists that are phenomenal, and they help us a lot.
Yeah.
And then the relationships that we're making with patients all the time, again, we see them over and over and over and over again over the course of a couple of years usually, or, from when they're 7 and we're just doing observation, we see them every 6 months. It's so cool to watch them grow, seeing adults grow, and not only seeing them, transform from a physical standpoint, but also seeing that emotional component and that confidence grow as well is amazing.
Yeah, I just had an adult patient that was so cool, literally just yesterday, and he had his braces on for 2 years. We took him off, and he came in to get his retainer, and he was just like, I I got in my car and I looked in the mirror. He's like, I realized I haven't smiled in so long. He's like, I'm so proud of what I look like now that I can't believe I actually show my teeth. He's like, and he's a big guy. He's like, he's not a softie. And he was like, I actually teared up a little bit. So it's just stuff like
That's
that.
awesome.
For us.
There we go. Okay, so our typical day, we usually start with a little huddle with our team and just kind of go over what's going on, if there's any big cases or this or that, or things that we need to talk about, like scheduling and whatnot. Usually we see about 65 patients a day, types of appointments. We have consultations where it's either a new patient or we do observation appointments where it's a patient we had seen in the past and we were just kind of waiting and observing their growth and development to see when they're ready for any treatment. Starts where we're actually putting braces on or putting Invisalign on or things like that, when we're actually starting the treatment, delivering appliances like expanders or space maintainers or different things. Adjustments, that's the bulk of our appointments. So that's going to be where we're taking the wires out of the brackets, either switching to a new wire or doing something to continue moving forward with treatment. Debond, which is the removal of braces. And then we also like to do some gingivectomies where we just do a little contouring of the gum tissue. Usually we wait a few months after.
We use a Picasso laser to do that.
And it just kind of helps sculpt things and make things look a little more symmetrical. If it's, anything extreme, then we obviously refer to a periodontist because they are gum tissue specialists. But if it's just minor and cosmetic, we can handle that in the office. And then retention is just retainer checks. And then we also started doing Botox recently and we love it.
And so does our staff.
Yeah. So a lot of our day also is spent, like we talked about, where Dr. Otto and I are just discussing cases. So you can see us FaceTiming. She was on vacation and always is working. And then a lot of the day, which is a little bit more on Dr. Otto's plate, is the practice kind of building, the practice management, and that kind of side of things.
Awesome.
All right. So why do people come see us?
So, parents a lot of parents think you have to have a referral basically from a dentist, and you don't. I mean, just come see us whenever you want, but typically we're not doing much in primary teeth alone, so we typically want to see patients when they're starting to get those 6-year molars and the front 4 teeth. So the American Association of Orthodontics recommends that children come in at age 7. Again, a lot of people, I think, have a misconception that they're going to bring their child in and we're going to recommend to treat. So Dr. Fraundorf and I, we always explain to parents that we have a very conservative approach, and I think they really appreciate that. So we do what's called phase 1, which is early treatment. We do that when it's necessary. Basically, there is a school of thought with some orthodontists and some, that are direct competition with us that believe basically in almost every case that comes in, you need to do what's called arch development, make more room for the teeth, and pretty much every child gets phase 1, where we don't do that. I mean, we do it because it's necessary, but if you don't need it, you don't need it. And I think parents really appreciate that about us, just being open and honest. So basically, for the most part, when a child comes in, we're going to obviously look at the aesthetics. We look at the obvious. We're going to look at the bite. We're going to look at the crowding. We're going to look at the spacing. And so we're going to explain to the parents, hey, here's what we see. And it's surprising. A lot of times, like, the teeth will look, fairly straight, but they have this massive overbite. And the parents really had no idea. When you have the pictures blown up on a screen for them, they're like, oh my gosh, wow, I can see what you're talking about now. We have patients that come in that a lot of adults that we treat, I'd say the majority had ortho when they were younger and they have relapsed because they didn't wear the retainers. So we treat a lot of adults. And again, most of them are because of relapse. We have
direct to consumer advertising, I feel like, has really increased the amount of awareness of orthodontics. It's a really interesting concept because a lot of people I know going into the field are like, oh my gosh, you guys won't have a job in, X amount of years. Fortunately, we will, because a lot of this, either A, the patients wouldn't be getting anything anyway. So, those patients wouldn't be seeking us out. B, it does increase overall kind of general public awareness of teeth, alignment and orthodontic treatment and aligners in general. And then also we have a lot of patients that go and do that treatment first and then get really messed up results and then come to us. So those are very, very sad cases, and it breaks our heart. But that direct to consumer, I think, does increase a lot of patient awareness of just orthodontics in general. So a lot of friends and family will refer, their friends and family, or, moms are talking and stuff like that. So we have a lot of people that come to us from that. And then again, kind of with that direct consumer is social media. So, the kind of older school, which is still relevant train of thought is, you get referred to a specialist by a dentist, just like you get referred to a specialist by your physician. However, with orthodontics, it's different. You really, most of the time, we don't have referral, or patients don't have a referral to come see us. So I have a lot of patients that message me on social media and are like, oh my gosh, I've been thinking about Invisalign. I really want to do it. I don't know what to do. So, we talk about consultations and stuff like that. And so we get a lot of people that just directly come to us or seek us out, whether they see us on the street or whatnot. Okay, so the different services. So Dr. Otto kind of touched on this phase one. So phase one is early treatment. So early intervention is really anything before you have all of your permanent teeth in. So like she said, we're very conservative. And that's another thing that I wanted to really make sure that we were on the same page with, because I would not be able to sleep at night if I practiced the way that some of our colleagues practice. We tell the parents, we absolutely do not want to do treatment on a patient that doesn't need it, because it's not worth it. Number one, the health and hygiene concerns, especially in a young kid, it's not easy when that manual dexterity is not developed until like age 10 or 11, I think it is, for them to be brushing, let alone brushing with all of these appliances in their mouth.
Right.
So the hygiene issue, the obvious finance issue. So it's just, we don't want to do that if we don't have to. And I mean, we want to be able to sleep at night. So if we need to, it's going to be, because of a growth situation. So if a patient has something where we can't obviously create growth, but we can modify the direction of growth with different types of appliances, as she was talking about expanders before. So if there's a crossbite and we want to do some expansion, that suture, the upper jaw is made of two different bones, and there's a suture that connects them, kind of like a soft spot in a baby's skull. It hardens over time and kind of locks up. So, we explain to the parents that, the longer you wait to correct that, the more likely it is that it's going to be fused. And so we do like to correct those early. So we like to correct posterior crossbites, anterior crossbites early. We want to make sure that no teeth are going to be blocked out or become impacted, which would then need a surgical intervention later. So we're just trying to prevent any big issues down the road. But like she said, I would say probably 90% of the time we either do nothing and observe, or we recommend taking out a baby tooth or two. When canines, especially on the upper, are coming in really angled, if you simply extract a primary tooth at this right time, it can kind of create that path of least resistance, and that permanent canine can kind of reroute on its own, as long as it's not crossed over the canine, or the canine's not crossed over the lateral more than a certain percentage. So there's a lot of things that we can do conservatively, as long as we catch it early enough. So along with that, kind of space maintenance. You want to talk about space maintenance?
Yeah, and so on the last slide, there was an expander in there that we were talking about. These are basically space maintainers. So on the left side, I don't know if it's flipped for them. The left side is a lower lingual holding arch. So basically, if you lose baby teeth early, we have to make sure that the molars in the back are not going to slide forward and basically take up a lot of the room that we need for the erupting teeth. So this is just such an easy appliance to cement and hold space, and again, make that future treatment so much easier. That's the main goal of phase one, is to fix problems now so that we have way less problems later. And then on the right side is a Nance appliance, basically the exact same thing, but on the upper arch. So there's lots of other things we can use, band and loops, distal shoes, just again, catching something early to make sure we don't collapse our space and then we don't have room for those teeth to come in. Because sometimes if we see kids early enough, we're absolutely gonna prevent them from having permanent extractions later. Because when we get old enough and the arch is already developed and then we have no room for the teeth, well, then usually we have to extract in those cases.
What's nice with these too is that they're passive appliances, meaning that they literally just sit there and hold things. They're not pushing anything. So it's not an active force, meaning it's a little more comfortable for the patient to just have this sitting there versus doing a full set of treatment. And financially, these are a lot less as well. So, all right, so comprehensive, full kind of orthodontic treatment. So this is the classic when patients come in, that standard age 12 patient that comes in, oh, I want braces, that kind of thing. So we have different styles of braces. We also have aligners. So clear aligners is just a series of those clear plastic trays that have a little bit of tooth movement programmed into each of them. There's different brands. We use, I would say, 90-something% Invisalign.
We've tried some new brands recently. There's a ton coming out right now. So we've dabbled in like 2 or 3. And it's a really big commitment. You pretty much have to commit to something and master it. And we basically have decided to go with Invisalign because that's what works best for us.
Yeah. So with that, you're not only learning how to use it chairside, but you're also learning how to use the software. So that's a big, like she said, a big kind of investment of time and energy.
And that photo we also have, and you can see it there, next one too. I think it's kind of cool. We have a couple options for braces. So the middle picture of braces and then on our assistant is what's called a champagne color brace. Oh, and on the right side too. So I don't think everybody offers those. They're a newer brace. They're a little bit more expensive than the traditional metal, but they look so good. They're just like a softer look on the tooth. They're not as contrasted with the metal. And we have tons of people loving those. Actually a smaller brace too. They have their profiles a little bit shorter. But then we have the clear, which are fine. They're just a little bit of a bigger brace. They're not my favorite, but some people like them. I'd say the majority of our adults do the champagne, and then obviously the most popular is going to be the metal for the kids.
I had braces when I was 15 and then again in residency because I wanted to kind of tweak a few minor things, but I did clear braces both times. I didn't have champagne as an option. I don't know if I would have gone with it or not. But I will say with the clear, if you're doing a traditional twin bracket, which is what you guys see on the right side, where it has those 4 little squares at each corner of the bracket, and you have to put that O-tie, that little rubber band around it, that will stain. So luckily, I was changing my own O-ties every week, and with the coffee I was drinking in residency, it was probably a good thing. So otherwise it stains really, really, really yellow. With the ones that we have, the ones that are up top, those are self-ligating. So we use self-ligating. There's a lot of different kind of trains with that with orthodontics. We use self-ligating for the aesthetic component versus the mechanical component. We use twin brackets for all of our other cases, but in the clear, we like that you don't have that O-ring to stain.
Yeah, so the self-ligating actually has a window. It doesn't use an O-tie.
That little door that kind of closes up.
And a lot of people will come in and be like, yeah, don't the clear brackets stain? We're like, no, I mean, they used to, or if you use this kind of bracket, but ours don't stain because they don't have that rubber piece that stains. It's not actually the brace staining, it's the elastic around it.
But the clear, I will say, absolutely, they're definitely a lot bulkier. There are little wires that are Teflon coated, if you guys have ever seen those, that are like the actual white coated. I tried those for the first weekend. I got my braces on a Friday in residency, and by Saturday I was ready to take that thing out because it was chipped up in all different areas from brushing, and it made it look like I had food stuck in my teeth. So there's really not like a completely like perfect aesthetic option if you're looking for something less visible. But what's nice is right now we have masks, all the time. So it hides everything. All right. So Invisalign.
So we've been doing a lot of Invisalign now. I mean, if you would have asked me 5 years ago, my mindset would not have been the same. Invisalign's come a long way with using their smart track material, with their attachments, with all the research they've done. So Invisalign can do a lot more now. And I also am a lot better at it. There's so much you have to learn about, like a tooth moving with plastic versus with a brace is so different. And so you have to learn how to move teeth with aligners. And it takes a long time. It takes learning the software, doing your CE. I took a very intensive course, but it's also just treating a lot of patients. A lot of times you have to over-engineer in the software because you're not going to get that expression in an actual patient's mouth. But now, I mean, I pretty much, anybody that comes to my office, I can treat with Invisalign or braces. So we pretty much give, I'd say 99% of patients the option. We have this cool scanner in the middle. It's an iTero. So we don't take any impressions for the most part. We just use the scanner. It creates a digital image, and we can send that to Invisalign or send that to a lab, and then basically get any appliance or our aligners made off of that. So patients really like that.
I will say I had at my corporate offices before I was with Dr. Otto, we had the physical impressions, the PVS, and yes, obviously from a patient perception standpoint, it sucks. Like it's miserable to have this big thing in your mouth and have it in there for a while and, the gooiness and all that stuff. But from a clinical perspective, I had so many cases that did not fit well, where I got the Invisalign trays back and I was like, oh, great, we're going to have to send them again because the molar doesn't fit at all, or they trimmed off this tooth because that wasn't working. So just from a precision standpoint, the iTero it's phenomenal. It just takes everything to the next level. And then also patient education, being able to show them what their teeth look like and kind of spin around in 3D.
Oh, the simulator. So when in iTero with Invisalign, you could scan a patient and within about 2 minutes, you can show them a simulation of what their teeth are going to look like. Mm-hmm. So for case acceptance rates with especially our adults, it's huge. It's really helped them see like, oh my gosh, my teeth can look like this, and it helps them be like, yeah, I definitely want to sign up to do this. And then at the speed, I mean, when I send a scan in, I can get a CLIN check back, which is the little video that you work with to make your aligners within a couple days versus mailing a PVS impression to Costa Rica and waiting for them to get it. So the speed that I can get my cases back is much, much, much faster.
Yeah. And then this is Annalise. She's so cute. She is one of our team. And she actually did a hybrid case. So that is something that we do a lot of the time. There's, like she said, we don't ever really, we do sometimes. We say, you know what, Invisalign's not going to be great for you. Sure. It's going to take 10 minutes longer, but very, very rarely. We want the patients to love how they look during treatment and, be compliant and not be miserable for the, year, 2 years of treatment. But we also obviously want it to be the most efficacious and fast and possible. So we do a lot of hybrid cases where we start with braces. Usually with these patients, they're a little bit more aesthetically inclined. So we usually do the champagne braces. And then we switch over to Invisalign after those really challenging movements are accomplished. Sometimes also if we have like AP, which is the anterior posterior, that forward backward movement, like a really class 2 patient where the upper teeth are way further ahead of those lower ones, we can start with a carrier appliance where it kind of helps bring things back and get basically that heavy lifting out of the way so that when we get into Invisalign can be nice and quick and the hard stuff is out of the way.
Yeah. How I explained
that was going to be.
Oh, sorry.
Sorry, I was just going to say that was going to be my follow-up question to this slide is what are essentially the clinical limitations of clear aligners? So.
It depends on the movements, so plastic is good for pushing. That's what plastic does. Braces actually can grab the tooth and pull it. So they're just a totally different mechanic. So there's certain movements like lateral incisor is very difficult to pull it down with Invisalign. Definitely can do it, but braces are going to be easier. There's certain torques on teeth that are going to get a little bit easier with a brace or a really rotated tooth. So now there's ways that we can actually kind of utilize a little bit of braces and then use Invisalign for the very little details. That's what it's so good at. And I kind of explain it to patients, it's like, let the braces do the heavy lifting initially. So a lot of times with hybrid, we say, get in braces for 4 to 6 months. Let's get some of these major rotations out. And then we'll go into Invisalign and we can fine tune, because I get this 3D blown up on my computer and I just move each tooth exactly where I want it. And then we just let the plastic work. So it can really do the fine detailing efficiently.
Right. Awesome.
All right. So like we said, we also started doing BOTOX. We really like kind of implementing this. It's just an interesting thing to be able to offer for our patients. We had a lot of people ask us, and, as, face, head and neck specialists, it's something that we wanted to get into. So it's kind of funny. These are the only needles that we have at our office. Yeah. We don't even do injections intraorally anymore. So that's just kind of a fun aside.
But a big reason why we started it was, to be honest, I started it so she could do it on me and I could do it on her. But for gummy, like we have people that come in with gummy smiles. And so we can tell them like, look, we can do a little Botox right here and right here, and it can decrease that gumminess. Or talking right. Some TMJ, just helping that. We do masseter injections for grinding, clenching. It's like, it takes 30 seconds and it's like the easiest thing. And we've had a lot of people had really good experiences with that. But we also, if somebody has really thin lips, we talk about, we don't do lip filler, but talking about doing some lip filler to help with that gumminess or to help the aesthetics of kind of everything they're looking for, because sometimes orthodontics alone isn't going to do that. So it's nice that we're knowledgeable on those things as well.
It's a really, really good point. So we, one of the things that we've been working on kind of the past year or so is really developing relationships with different aesthetic groups in St. Louis, different med spas, different plastic surgeons, different nurse practitioners that do aesthetic things, because we do have a lot of patients where, you know, if they come in and they're what we call mandibular retrognathic and that lower jaw is too far back and they don't want to go through the full jaw surgery, that orthognathic surgery to advance that lower jaw, and we're doing a compromised dental, you know, the orthodontic treatment, moving the teeth to kind of camouflage it, their soft tissue is still going to reflect that. So we have a lot of patients that, you know, have that chin really tucked back, and we say, okay, well, let's send you here and let's talk about doing whether it's fillers or a chin implant or a genioplasty, where they actually move the bone itself, where it's a little bit of a, you know, it's a surgery, but it's a lot more minor and a lot less invasive than doing your entire jaw. So we like to kind of, you know, involve that realm of things, because orthodontics, or the teeth and their position, is so much related to your lip position and your overall facial balance. If we have a patient's teeth that are way too full and proclined, if we do extractions, we can tuck them back, and then hopefully they can get their lips to touch relaxed, not have their tense mentalis where this muscle is straining to close. So there's so many relationships between those two worlds that we kind of, within, you know, the last year or two, we really started to kind of mesh those worlds. And I mean, I give out referrals to plastic surgeons all the time and med spas and things like that, because that's, you know, it's something that bothers the patient and they are trying to communicate with us, and we're trying to see, you know, okay, well, if we move your teeth like this is how it's going to react. Yeah. And here's other ways to kind of help it. So
that's amazing to hear that your practice, this is essentially employing an interdisciplinary approach to clinical care. That's awesome.
For sure.
Yeah, we love that kind of interdisciplinary with everything. Okay, so let's talk about a couple cases. So we've got two cool ones for you. We decided to pick out two adults because we find that adults are a lot more challenging, a lot more interesting sometimes. And I know there's been a lot of other orthos on here, so I'm sure they did a lot of kids cases. So,
and the kids have horrible hygiene, so their pictures are terrible.
Yes.
It's better.
Okay, so I'll talk about this one. This one's Stacy. So Stacy is so adorable. We love Stacy. She came in and she's like, I don't like my crowding, which, you know, you can clearly see that upper incisor is extremely rotated, lowers severe crowding as well. And she also said, but I want Invisalign. And we said, oh my gosh. And, you know, we didn't want to do extractions if possible. Now, again, it's a spectrum. As far as extractions, non-extractions, we're more on the non-extraction side if it doesn't compromise the hard tissue health and also the soft tissue aesthetics. So if we procline them out too much, like we just talked about, their lips won't be able to touch. Nobody wants that. And then again, if you flare those teeth out too much, you can compromise, you know, the bone support on those lower incisors. So if you look at the Ceph, you know, we don't want to flare them too much. So we have to kind of figure out a way to alleviate that crowding.
And if you look at her profile and her lips, so she's a little bit of a flat profile. So if we were to take out 4 teeth, she is definitely going to be a little bit more ditched in. And so for her, we really took her lips into consideration, especially in the non-smiling photo and the profile. I mean, she could use some more lip support. So that's another reason why we went that non-extraction route.
We also look at when they smile, the amount of gingival display they have and their depth of bite. If they have a lot of gingival display, we absolutely do not want to take teeth out unless we totally have to. And, you know, vice versa. If they don't have any and we want to kind of drawbridge effect, bring things back, then we want to consider that as well. So in her case, she has a beautiful smile. We just wanted to kind of straighten some things out. So we told her with a kind of little asterisk, we're going to do this non-extraction, but we're going to do some IPR where we do a little bit of slenderizing. We always tell patients there's, you know, several different ways that you can get rid of crowding. Number one, the most obvious, take teeth out. Number two, do a little bit of slenderizing to get that cumulative effect of space. And then number three, flare teeth. Obviously, flaring has an extent to how much you can do it, as does removal of a little bit of enamel in between. So With her, we started that hybrid approach because we knew she wanted Invisalign, but we said that lateral is never going to move with that Invisalign. So this is her 6 months later. So she just had braces here. She had a little bit of IPR. So I'll show you the kind of before and after. So we did not address any of the class 2 yet. We'll address a little bit of that during Invisalign, but for the most part, we're trying to get as best as we can with these cases.
Yeah, so I mean, this is just 6 months with braces, and now we're going to go in and basically fine tune everything. So, had she stayed in braces the entire time or the Invisalign the entire time, I bet there's a 6 month swing. So we're hoping that we can get this case done in maybe around a year. But I'd say typically that would probably take 18 months if you just went straight braces or straight Invisalign. So this was an awesome option for her.
Yeah, so
Yeah,
she's
wow.
so great, and she's so happy with that lateral on the upper being rotated now.
700.
Okay.
Let me take this one. This is Chuck. So he came into the office, and this was 2018. So a couple of years ago. And so I really actually wasn't doing hybrid as much then. If he were to come in now, I would 100% please do hybrid a little bit on the upper, just to get some push on those incisors. But actually his Invisalign went awesome. So for him, he is what we call a little bit of class 3. So if you look at his upper and lower jaws are kind of right on top of each other. So you usually want that upper jaw just a little bit in front of the lower jaw. You can see in his bite, he's what we call edge to edge. So he's been wearing down his teeth quite a bit. His top 2 front teeth and then his bottom incisors, the enamel's worn down because of where his bite is. So this is a great case to actually take out a lower incisor. So we took out a lower incisor on him, and this is where he was. I think we were at like 13 months, 14 months.
Yeah.
And his case went really, really well. But I think that has to do with, again, the engineering of the ClinCheck in Invisalign. I had to do certain things on the lower incisors to make sure where we had that extraction space, that the teeth didn't just tip into the extraction space. We had to do special things to make sure they bodily move. And he was a super, super compliant patient, and his case turned out really well. We had to do a little bit of interproximal reduction. Probably could have done a tiny bit more on the lower to maybe get what we call the little black triangle to go away. But we did a lot, and we kind of thought, okay, well, that's about as much as we can do. And he was super happy. So.
Amazing.
So a few questions from Instagram we'll try to fly through because I know time-wise we're kind of running out. So what traits do successful orthodontists have? I think obviously you want to be well-rounded because you want to be able to interact with the patients and kind of relate to them. A lot of our patients are younger, so trying to talk at their level and what interests them and things like that. Obviously you have to be able to multitask and try to.
I feel like it's a super competitive field right now, and people are getting 2 and 3 opinions. So I really feel like we stand out because we're relatable. Like we talk to the parents, we talk to the kids, we're fun. And, I feel like people leave our office being like, oh my gosh, I really liked them. So to have a really dull and monotone voice like that, you're not going to get that patient. I'm sure you're going to get some, but we get a lot of second and third opinions that stay with us because we have a fun office, because we feel like we're fun doctors and we have good personalities.
And we do have fun.
Yeah.
So, okay. Tips for high school seniors wanting to go into ortho. I would say grades are number 1, and number 2, start shadowing and getting your, feet wet in the world of dentistry or ortho.
Yeah.
Challenges of applying to residency.
Obviously you have to do it while you're in school. It's expensive, and you're concentrating on graduating dental school, but you also have to concentrate on applying and interviewing. So yeah, it's hard, but yeah, you can do it. You can multitask.
How competitive is it to match into residency? Do only the top of the class get into the residency? Kind of funny. So I graduated valedictorian of my class, and I did not get into my top choice. So yes and no. You have to get good grades, but the connections is where it's at. So I did not necessarily want to go to SLU, but I'm so glad I did. It was a phenomenal residency. Learned so much. I loved the class size. So, it all works out, but grades are number 1. It is super competitive. Know how to play the game and you'll be fine.
Mm-hmm.
All right. So what's the most valuable thing you would tell those pursuing the field?
I mean, I think just like I think in this day and age, you kind of have to know what you want to do early on, because unfortunately, you have to start stacking that resume,
Yeah.
so you can't just wait until, you're a senior in college. That's just it's not going to cut it, So I think it's trying to figure out early, the shadowing as much as you can, getting the experience. I mean, everything we've already talked about, you've got to make it look like you stand out.
How do you
Right.
feel, or how did you feel as a student pursuing orthodontics versus actually being in the field? I mean, it's hard because when you're in school, you're just like, laser focused on studying and studying and studying and studying and studying. And then all of a sudden you're like in the field and you're like, oh my gosh, this is like real life. This is amazing. I'm happier than I thought I would be, to be honest. I just love it. Love it. It's amazing.
I mean, we really, a reason why I went into, dental, not med, is like, I don't want to get those calls in the middle of the night. Quality of life is fantastic. I mean, I travel and we could take time off, and I don't really get a lot of emergency calls. So quality of life is awesome.
That is one thing about ortho, is the emergency calls really aren't like emergencies. So that's kind of nice. Usually you can talk to them about it and they can do some at-home like remedies. All right, different types of braces. We went over that. For the 2 to 3 years it takes to specialize, are you able to work or only study as a student?
A lot of people worked.
In my during
class.
residency?
Yeah, they shadowed. Are they, what do you call?
Moonlight?
Yeah.
We weren't allowed to. So we had to sign a contract saying we would not moonlight.
Really?
The only thing that we did was like Boys and Girls Club. We would do like work there. But yeah, I did not
I'd
work
say it
during
was like
residency.
50-50 for me, but it's changed. Obviously, it's been 10 years. How hard is school? I mean, how
really
hard is school? Yeah, hard.
Really, really
yeah. Work hard. Yeah, work
You
hard.
don't have, you have to be at the top of your class. So top of your class, I mean, I think that when I was looking, they said you have to be top 10%.
Yeah.
Is that what you? Yeah. Okay. So top 10%.
Yeah.
Braces versus Invisalign, Smile Direct Club. We kind of talked about
Yeah.
that, but Smile Direct Club and all those other DIY orthos don't have orthodontists really. Some of them might say they do, but they really don't even look at the case. They just are like a figurehead of this, company so that they can be legal.
They're called click monkeys. That's what they just like, okay, yep, accept.
Yeah. What is the match process like? So match, I mean, you get interviews, you go to interviews. It's all like within 1 month. I guess now it's probably different because it's virtual, but you go to whatever interviews you can. I know I had to turn down, I think 2, because they were like the same days as the other ones. So you have to kind of prioritize. When I did it and when you did it, we had to travel. So you have to prioritize that too.
I think I did 15, and which is a lot but I applied to like an insane amount of schools because I was like, I don't care what I have to do. I want to get into ortho and I want to get in this year. So I applied to a lot of schools, got a lot of interviews. And I think it was almost like 10 grand or something with like all the travel and
I don't remember. I blocked it out. It just becomes monopoly money once you're in school. So what's the match process? I mean, so you rank the schools and they rank you after your interviews, and then the algorithm, like the magic sorting hat of Harry Potter, puts you somewhere magically. So then you just find out one morning and then you go where you match.
Right.
And
life-changing.
Yep. All right, cool.
That's it.
So that's it. Feel free, if you guys want to reach out to us, we would be more than happy to help you guys with anything that you have questions on or, want to talk or whatever. So we've got both of our Instagrams, so the Otto Ortho practice page, and then I have one as well. And then we've got our Braces by Warby's TikTok, if you want to follow us and see us make fools of ourselves. So.
Awesome. That was amazing. Thank you for providing us with such a comprehensive presentation. At this point, I think we have enough time to answer a few questions from the chat. So I'll hand it over to Alexis, and we can take a few questions from our viewers.
Yeah, so one of the viewers are asking, what are your opinions on lingual braces? Are they just as effective as traditional braces?
Good question.
So I practice where I would never do something on a patient that I wouldn't do myself or a child, my child or something like that. I had a lingual button on my upper second molar when I was in residency to try to, wear elastics and pull it down. And it was the most miserable thing of my entire orthodontics, everything. It was horrible. It ripped up my tongue. I couldn't talk. I couldn't eat. It was horrible. And the rest of the braces, like, it's braces. They're not like fun, but they're braces, it's fine. So that I couldn't get over that. And so from that standpoint, from a patient perspective standpoint, I was like, absolutely not. I've had another patient that actually came in the other day that was treated 8 years ago at our practice, and she was treated with a different practitioner that was there at the time that was doing lingual braces. And she was like, I had them on for 24 hours and I had them take them off. I couldn't do it. So I've just, from a patient perspective standpoint, I think.
Yeah, we don't do it basically.
No, absolutely not.
And first of all, I truly,
mechanics, though.
yeah, I truly feel like they're harder mechanics. So for me, I'm not going to treat efficiently with them, and I think they're extremely uncomfortable. So we don't offer it.
Yeah, the concave versus convex tooth surface, I just can't see the. No.
Yeah. So no, we don't like
hygiene. No, hate them. Sorry.
Okay, thank you.
Good question.
So this question is actually from a D1, not a pre-dental. And they are asking, is the residency debt overwhelming?
Yeah. But I think it's the whole kind of package is overwhelming.
Yeah, I mean, it is, but it isn't. I mean, could I go back and do it right now? I mean, it'd be hard, but like, it's doable, you know? I think the thing that was a little hard for me was like, you get through dental school and I was like, oh, but you can't do that. You know, you're jumping right into a residency. But I mean, you've been used to doing that your whole life, you know? So it's like, you know what to do, you know the effort you have to put into it. And honestly, you do a lot of the academics that first year, and then it's a lot more clinical, and that's the fun part of it. So I don't know. I mean, it's doable. Yes, it's intense, but it's doable.
Okay, next question is, how do you go about finding more about a school beyond what's on their website without being annoying to staff/faculty?
That's a good question.
Yeah, I mean, I think you do what you can on the website, and then, yeah, you have to just try to find, you know, I think a lot of faculty would be totally open to talking to you, and I think you can go shadow anytime you want. So I think shadowing would be huge. Asking as many questions as you can.
I think a lot of schools have made videos though right now, and it literally is like a 5-minute thing, and it literally shows you everything about the school. I know our assistant that had an interview at a school was like, yeah, they showed us a video, so I already knew everything. Because I was like, how are you going to go to school without knowing what it's like? And she's like, oh yeah, we saw a video. And I was like, that's amazing. I know SLU had one because they posted that on the Facebook group that we have. But I think, you know, like we said, making connections. So you might follow a dentist that's in LA, and they might have a hookup at USC for you. So, you know,
finding an alumni too, like on social media.
Oh, yeah.
I mean, I feel like everyone is, I don't know anyone that's not willing to talk and help out. I mean, pretty much everyone I know is be like, oh my God, I'd love for them to come to my office and talk to them and help them.
Cool. So someone is asking, there are a lot of emerging opinions on the future of ortho. Many say that because of saturation, high tuition costs, and many general dentists doing ortho, that going into ortho just isn't worth it anymore. I'm wondering if you could speak onto what the future of the ortho specialty is, and would you encourage people to pursue the specialty?
I think they've been saying that for like 50 years.
Yeah.
So I don't see it going anywhere. Yeah.
The only thing I see changing and what everyone's worried about is, you know, the DSOs and our private practices. One little small practice, is that going to survive? You know, orthodontics, the field of orthodontics isn't going anywhere. GPs, you know, GPs do ortho, yeah, but I mean, there's a lot of ortho to go around, and there's a lot of complex cases. So I don't see it going anywhere. And I think, yeah, maybe there are going to be bigger groups that you have to, you know, acclimate to, but I wouldn't be worried about it. No.
And we have a lot of relationships with general dentists that, you know, will help them with clin checks, or will help them with stuff. And, you know, then they'll know when their, you know, extent of knowledge is reached, and then they'll be like, okay, this is too much for me, you take this. So, you know, there's plenty to go around.
So the next question is what are your favorite marketing methods for your ortho practice?
Marketing, yeah.
I mean, social media is huge right now, and I've been flabbergasted at how many people come in that just say, I found you on Instagram, I found you on TikTok. So that's been huge. I feel like our name has really been getting out there since Dr. Fraundorf has been helping with getting our presence on social media. But we still, try to get dentist referrals. We drop off baskets and I try to do lunches. For me, I think getting to know the dentist, showing them that you do good work, that you care about your patients, helping them whenever they need help. So you still have to have those dental
the traditional
relationships, but then it's social media, and then it's really the community. All the moms talk, and they are going to talk to their friend, and it doesn't really matter who their dentist told them to go to. They're going to see who their best friend goes to or who their neighbor goes to. So getting in the community, being very present at schools around you, I mean, that's been huge too. So I feel like it really comes from, it's definitely not one. I mean, it's really equally like 4 different pots on where you're going to get people from.
And like she said, people talk. So you got to keep your patients happy, and they will tell 20 people. So,
yeah, having we really pride ourselves on like customer service and, making sure, again, we have a fun office and we're treating people well. And I think if you do that, your name will get out to the community and you'll do well.
So, do you recommend for pre-dental students to take business classes now in order to prepare for the future?
Oh my gosh, I love that question. I had I don't know if she was pre-dent or what she was, and maybe high school, I think actually. She messaged me and I sent her a video back and I was like, the number one thing I can suggest that you study is business, because that is one thing. I was like, I mean, Spanish is cool, art is cool, but like, I wish that I would have gotten at least a minor in business, because it is so important.
And they don't teach you anything in ortho or dental, nothing. 0.
So yes, 100%.
Just to sort of segue off that question, how did you two acclimate to sort of the business and managerial aspects of running and having a private practice?
I'm learning.
Yeah,
so that's all you.
I mean, it's like once you master and see, so if you do a startup, you start so slow because you don't have a lot of patience. So I think for a startup, you can learn the ortho and you can learn the business and the protocols, because it's such a slow process. For me, I liked coming in as an associate so I could learn the ortho and I could see how the business was run and see what I didn't want to do and what I wanted to do. But it takes time, learning how to deal with staff, how to have, staff retention. It's just basically learning by doing, it just takes some time.
I think also not reinventing the wheel. I know,
huge.
Dr. Otto just recently was like, oh my gosh, we're going to implement this thing. It's so cool. I, talked to X, Y, and Z people on this Facebook, study club, and they said it's amazing. We're going to start implementing it. So things like that. I mean, even you've owned a practice for how long? And like, she's still learning every single day. So
6 years.
Yeah.
I had a consultant come in when I first bought the practice, again, because I just wanted to make sure I kind of know what to do, but why I know this person knows 2,000 other people that have done this. So I had a consultant come in and just kind of help me set up some initial protocols. And then we've tweaked those, oh my God, along the way so much. And we're still tweaking things.
Awesome.
So what would you say your most challenging case was, and how did you approach it?
Most challenging case? Probably surgical ones that don't want to do surgery.
Yeah. I mean, talk to each other. I mean, initially we're going to take a full set of records and then we're going to take time to go through it. Her and I are going to talk, and then we'll probably send it out to 10 of our friends too. And we're going to have 10 heads come together and say, okay, what is going to be the best for this patient? Might talk to we always we have a lot of oral surgeons that we're friends with. Let's go let's get a consult with them, talking to their dentist, making sure everybody's on the same page. So I think it's just doing your homework and then providing the best diagnosis and the best explanation to the patient.
I think being open to continuous learning is so important too, and not being like, oh, I know everything. Being able to say, you know what, this is a really tough case. I could treat it 3 different ways. What are your thoughts? What are your thoughts? What are your thoughts? So just being able to take in that information and continue learning. And
Amazing. Well, I think just in the interest of time, I think that was a very fitting end to today's wonderful presentation and wonderful virtual shadowing session. Doctors, we want to thank you again for your willingness to join us, and also for your effort to help students sort of navigate their pre-dental paths, amidst such a, unfortunate situation. But before we conclude, I do want to remind the viewers that the quiz should be posted in the chat, and it can also be found in our Instagram bio. On that note, I want to wish everyone a great evening, and I want to thank the viewers for attending. Thank you so much, doctors.
Thank you,
Thanks.
guys.